Assalamu alaikum, it's Nanya and I'll go through the upper limb fractures. All of the upper limb fractures are summarized in this table. Of course, the information is a little bit summarized. However, we will go through the most required information for undergraduate examinations. First of all, let's start with clavicle fracture. As you can all see, clavicle includes double C's. Why? Because we have two important informations about the clavicle fracture, starting with letter C. Number one, it's the commonest fracture in the body. Number two, the main line of treatment is conservative treatment. If we have put the two C letters above each other and rotated them, then we will have number 3. Why? Because we have many informations depending on number 3. Number 1, the conservative treatment will last for 3 weeks. Number 2, the clavicle affects 3 ages. There is trimodal distribution of the clavicular fracture. Number 3, the clavicle is divided into 3 parts anatomically. Number 4, clavicular fracture usually associated with 3 main deformities, and it usually results with 3 main complications. So let's discover the clues we have just said. Number 1, the incidence. It is the most common fracture in the body, and we have said this when we have said the information behind letter C's. Again, it's trimodal age of distribution. The clavicle is divided into 3 parts. The medial 1/3, which represents only 5%, and it is the least common. However, it's most commonly presented with non-union. The middle 1/3, which is the most commonly fractured part. That's why there is change of contour in the middle 1/3 and a change of the curvature, and also because it's a site of insertion of muscles, and also there is a foramen or a groove for the nutrient artery. And finally, there is the lateral 1/3, which represents only 15%. The most common indirect trauma is fallen out stretched hand, and there might be direct blow to the elbow. The clinical picture follows general scheme and is presented with swelling and limitation of movement, plus 3 main deformities, which are shoulder drop, is presented in this image, stepladder deformity, which is usually due to overriding, and number 3 is the position of lactating mother, in which the patient bends the knee to relax the sternomastoid and stops the displacement and supports the elbow with the other hand. This position where deformity will be easier if you could understand the displacement. What happens in the displacement of fractured clavicle? Number 1, the sternomastoid pushes the medial part upwards, and that's why the patient here will choose to bend the knee to relax the sternomastoid and stop the upward pressure by the sternocleidomastoid. There is the lateral part is pushed downward by the gravity and by the weight of the arm, and it's pushed forward and medially by pectoralis major. X-ray is usually ordered, and CT is preferred if there is fracture in the medial 1/3. The complications follow the general scheme, plus 3 main complications. The most common is malunion, and there is usually subclavian vessels entry and brachial plexus entry, as discussed in the general schemes video. The treatment is mainly conservative for 3 weeks, and this means that for children we will use figure of 8 bandage, and for adults we will use a broad arm sling for 3 weeks. If there is any indication for open reduction internal fixation, such as absolute indications open fracture neurovascular injury, and relative indications multiple trauma, fracture distal third, or displacement more than 2 centimeters, then close reduction external fixation could not be done. So we have known all the clues in the word clavicle, the double C's, and all the clues underneath number 3. Conservative treatment, figure of 8 bandage or broad arm sling for 3 weeks. There is trimodal age of distribution. The clavicle is divided into 3 parts, and it's usually associated with 3 main deformities as shoulder drop and position of lactating mother, and I can't remember, shoulder drop, position of lactating mother, and let's go back and check it all together. Yes, stepladder deformity, which is due to overriding. And finally, we have three main complications, which are a neurovascular entry, brachial artery, subclavian, and malleolus. Let's move to proximal humerus fracture. And as we can see here, this is an old lady because it's more common in elderly due to postmenopausal osteoporosis. The most common mechanism of entry is again fall of outstretched hands. And as you can see in our clinical pictures, there will be flat shoulder due to axillary nerve entry, and there will also be patch of hypoesthesia over the deltoid due to circumflex nerve entry. If the patient is indicated for open reduction, then screws and plates will be used. So first of all, what's the incidence? Again, it's most common in elderly females with postmenopausal osteoporosis. There is many anatomical sites, either anatomical neck fracture, surgical neck fracture, affection of the greater tuberosity, or lesser tuberosities. The traumas usually fall on outstretched hands. This results in surgical neck fracture. Fall on the shoulder will result in anatomical neck fracture or greater tuberosity fracture. The clinical picture follows the scheme, and the displacement is classified into Neer's classification. To easily study Neer's classification, we will order it 1, 2, 3, and 4. 1 with 0, 2 plus 1, 3 plus 2, 4 plus 3 displacement. So order the numbers 1, 2, 3, 4 and order the displacement 0, 1, 2, 3. For one fracture, there will be 0 displacement. If the bone is fractured into 2 parts, there will be 1 part displaced. If the bone is fractured into 3 parts, there will be 2 parts displaced, and so on. We will usually do X-ray, but the CT is usually better. And for the complications, there will be avascular necrosis of the humeral head if the fracture occurs at the anatomical neck. As you can see here, avascular necrosis occurs when there is interruption of the blood flow. This results in a vascularly necrosed segment and later on results in collapsed and fragmented cartilage. Axillary nerve entry results in flat shoulder, and this will affect the abduction, and the circumflex nerve entry will result in a patch of hypoesthesia. The treatment will depend on the Neer's classification, and this will depend on how many parts of the bone are injured. If there is only one part is fractured, then we will do the basic close reduction with external fixation, sling with early elbow motility. On the other hand, if the bone is fractured into 4 parts, then we will do the extreme intervention with prosthetic replacement of the head. There will be also injury of the rotator cuff, so cuff repair with wire loop fixation of the tuberosities. If the bone is injured into 3 parts, we will not be indicated for prosthetic replacement of the head. However, open reduction with internal fixation and rotator cuff repair will still be required. The main part is when the bone is fractured into 2 parts, because this will depend on which parts are injured. If the bone is fractured in 2 parts in the lesser tuberosities, then immobilization is the best choice. If it's in the surgical neck, then collar and cuff are required for 3 weeks, especially if this occurs in the children. If greater tuberosities, then we will go back to our main mnemonic, and we will remember that fixation will occur with open reduction and internal fixation by screws or wires, followed by sling and no abduction for 3 weeks. And so let's all memorize that the screws are mainly indicated for greater tuberosity fracture into 2 parts. So this is summarization as much as possible for the treatment part, and now let's move to the fracture shaft of the humerus. Again, this is an elderly female with postmenopausal osteoporosis, and here is a motor vehicle, because usually motor vehicle accidents are the most common cause for fracture shaft of the humerus. However, our car here has some mnemonic PRUH8I. Why? Because we will see the mnemonic of the secrets behind this mnemonic later on. Let's start with the fracture shaft of the humerus being more common in elderly and maybe also site of pathological fracture due to tumors, usually fall on outstretched hand or twisting injury, motor vehicle accidents, or direct blow. There is usually angulation deformity, and the displacement is due to abduction by supraspinatus and adduction by pectoralis major, followed by abducted by the deltoid. For the lower fragment, we will use the second half of the upper fragment. By this I mean there will be adduction by pectoralis major and again abduction by deltoid, but we will add adduction by coracobrachialis. What about our mnemonic? Our mnemonic in the card number, we said B for brachial artery NG, R because there is radial nerve NG which is represented with wrist and finger drop, and then we said U because the best treatment is U-shaped plaster slab, or H hanging cast 8 for 8 weeks, and if failed there will be interlocking intramedullary nails as the treatment of choice. So B for brachial artery entry, R for radial nerve entry, U because the best treatment is U-shaped plaster slab or hanging cast for 8 weeks, and if there is indication for for open reduction, I will be intramedullary intramedullary nails, interlocking intramedullary nails. So this is the image of the U-shaped plaster slab, and this is the image for the hanging cast, and both of them will last for 8 weeks. So we have finished fracture clavicle, fracture proximal humerus, and fracture shaft of the humerus. Let's move to supracondylar fracture. For the supracondylar fracture, we have this mnemonic. These are two boys because the most commonly injured age of supracondylar fracture is boys or children 10 to 15 years old, and especially male gender because they're usually hyperkinetic. And as you can see here, these boys are camping. While they were camping, the most common injury that occurred is fallen outstretched hand, which resulted in the most common type of the supracondylar fracture of the humerus, which is the extension type. These boys were camping, and the word camp will be the main mnemonic for the supracondylar fracture of the humerus. Letter C. First of all, children is the commonest age, and we have said 5 to 10 years old, especially the male gender because they are hyperkinetic. The second C, complete fracture, represents 50%, and the green stick fracture represents the next 50%. The third C, cubitus verum, is the more common deformity. Cubitus verum is more common than cubitus valgus. For letter A, we'll use ape-hand deformity as the median nerve entry, and arteries injured brachial artery, which is presented with the 6 common P's. For letter M, malunion is the most common complication, and the muscular complications are myositis, ossificans, and Bachmann's ischemic contraction. For letter P, we will know that posterior displacement of the distal fragment by the triceps occurs in the extension type, and the opposite occurs in the anterior displacement, in which in the flexion type, in which anterior displacement of the distal fragment by biceps and brachialis occurs in the flexion type. Finally, the last P will be about the treatment, which is posterior plaster slab for 3 to 4 weeks. And usually supracondylar fracture of the humerus is very similar to the posterior elbow dislocation. That's why the camp mnemonic is very important. Moving through our table, for the incidence, we have said that it's usually more common in children, especially males, and 50% green stick and 50% complete. Usually occurs in the metaphysis just above the 2 epicondyles and passing through the olecranon fossa. Usually fallen outstretched hand. If the elbow is slightly flexed and hand pronated, the extension type will occur, and if the patient fell on the tip of the flexed elbow, the flexion type will occur. Clinical type picture follows the scheme, with common deformity being cubitus verum, more common than cubitus valgus. Displacement usually occurs in the extension type, posterior displacement by triceps. In the flexion type, anterior displacement by biceps and brachialis. This is the difference between the extension type and flexion type. In the extension type, as you can see, posterior displacement of distal fragment, and in the flexion type, the distal part is anteriorly displaced, usually by biceps and brachialis. For the complications, we have the most common being malunion, and other muscle complications as myositis, ossificans, and Bachmann's ischemic contracture, brachial artery entry, and median nerve entry presented with ape hand. Radial nerve entry may also be injured, and ulnar nerve entry may also be injured, and all of these were present in our camp mnemonic. In our treatment, we have set the posterior plaster slab for 3 weeks. So includes reduction external fixation, posterior plaster slab above the elbow for 3 to 4 weeks with follow-up of the radial pulse. Now let's move to the last part, which is Colle's fracture. For Colle's fracture, it occurs in the distal radius. So the main words in our scheme is distal radius. Distal starts with letter D, so letter D will teach us number 1, it occurs fallen outstretched hand with associated dorsiflexion of the palm, and there will be three main deformities. Number one, dinner fork deformity, as you can see here, and ape-hand deformity due to median nerve injury or carpal tunnel syndrome, and last deformity is mid-lung deformity, which occurs in children due to injury to the epiphysis. The radius doesn't grow properly, forcing the ulna out of position. The radius will teach us some information starting with letter R, as radial artery nerve injury is the most commonly injured artery with Colles fracture, and this could be assessed by Allen's test. So these are the most common information about Colles fracture. We have said three main deformities, and reduction will be via three-hand crack method. 3 plus 3 equals 6, so fixation will be 6 months below elbow cast. 3, 3, 6. These are the main information about Colles fracture, and we have just said all of these information in the previous slides. We will just add some information in the complications. Sodix atrophy is usually associated with Colles fracture, and there will also be tear of the external pollicis longus tendon. Now let's add a little bit of details. We have two other fractures, which are Monteggia fracture and Galeazzi fractures. To summarize the difference between both of them, I have used this image from MedComic website to study the difference between Monteggia and Galeazzi fracture. You have to memorize the word mugger. As you can see here, this is a mugger. A mugger is a criminal. Mugger starts with MU and ends with GR. MU to teach us that Monteggia fractures occurs in the ulna. So this is the first information. MU, Monteggia occurs with the ulna. And as you can see here, Monteggia ends with an A. So A is the first letter in the alphabetics. It's an upper letter. So Monteggia fracture is associated with upper third fracture of the ulna, and the associated dislocation is also superior. So upper 1/3 ulnar fracture with superior to ulnar joint dislocation. Galeazzi fracture on the upper hand, the word mugger, GR, so Galeazzi occurs with the radius fracture. And Galeazzi fractures include letter Z or ends with letter Z. Z is the last letter in the alphabetics, so fracture occurs in the lower parts. Fracture occurs in the lower third of the ulna and in the inferior part of the radioulnar joint, the dislocation. So this is very important to be summarized, and it often occurs or often comes in MCQ questions. And short easy questions. So it's very important. Thank you so much, and I hope that this video will help especially foreign students in our faculty who cannot understand Arabic videos.